So I think it's okay, Dr. Sasson, if you want to go ahead and get started.
So we'll start off with some questions that are in the posed by the audience, and thank you. And I encourage all of you to do so. Some of these questions have specific clinical information, but I'm going to try to keep some of them general. And so the first question comes from someone who is talking about they have a pulmonary neuroendocrine tumor, had a right lobar lobectomy. And the question is, what's the importance, how important is it to seek out a neuroendocrine tumor specialist? For you, Dr. Ramirez, first, but then also to the other panelists as well. Even if this wasn't a lung neuroendocrine tumor, if someone is being treated or cared for, let's say maybe in a more rural setting where there's no access to a NET specialist, what is their best recourse?
So that's a very good question. I think this disease, the rarity of it. Again, I pointed out that the carcinoid tumors of the lung represent about 2% of all lung cancer. So we see lots and lots of non-small cells, small cells. But when it comes to the typical and atypical carcinoid tumors, your general community oncologist may see, they'll certainly see this, but it's not going to be their bread and butter, and may have a few patients in their practice. So there are some nuances to follow up. Again, one of the misconceptions is that this is a benign disease and you never need any more follow-up. So I do think it's important to at least get that, a one-time opinion, at least if you're not able to regularly follow up with someone, at least seek out, get that one-time opinion so we can develop a roadmap. What has happened this year and what we've learned how to do this year is we're getting very, very good at telemedicine. And I'm seeing patients from all over the country, which I did before, but I'm doing it remotely. So it's really good. The patients who can't travel, it's really nice. So when you say they don't have access to a NET specialist, well, I think in 2020 we all have access to a NET specialist. Because I think we're all doing telemedicine. We just presented our data at NANETS a few weeks ago, looking at patient experience in a survey with NCAN, and it looked like patients really had a good 90% of them had rated that experience as either good or excellent. So I think it's a good tool that we have. So take advantage of it.
I would agree. I think that the adoption of telemedicine has been beneficial, particularly for patients who have uncommon tumors such as these, to seek out specialists. Thank you. So, Dr. Wolin, so for the patient who comes to you from maybe a rural part of New York or even Pennsylvania, let's say, and they tell you, I can't make this trip every 3 or 6 months. How do you manage with those patients? Do you provide them with guidance of a schedule to get to their doctor, consultation? How does it work? How do you manage such patients?
Okay, I'm a neuroendocrine oncologist, so all of my patients have neuroendocrine cancer. It's a whole specialty, and we have a neuroendocrine tumor center, a carcinoid neuroendocrine tumor center. We have a big multidisciplinary tumor team with over 20 specialists in every kind of medical specialty relating to this treatment. And this is what we do all day. So it's a very specialized area. And in the community for these kind of rare diseases, people may go for their entire career and only see a couple of people with a lung neuroendocrine tumor, a pancreatic neuroendocrine tumor, or even an intestinal carcinoid. So you come to a center of expertise to deal with this, you could often get a much more comprehensive evaluation. So I think that I work very closely with oncologists everywhere. I see patients from all around the country. And I think everybody who doesn't live right in the vicinity and want to have their primary care at Mount Sinai has their primary care with their local oncologist. And we just work very, very closely with everybody to make sure things are happening. People need shots of octreotide or rarity every 4 weeks. They need blood tests. They need different things. Different imaging can be done locally, and then people can see me for an opinion. They can see me periodically, and reassess. They could see a time of progression and make decisions in conjunction with the local doctors about what should be done. We have certain clinical trials that could only be done at our center, but we have other treatments that can be done locally. So we just have to work together. But I think anybody with a rare disease like that really deserves the opportunity to talk to somebody who's a specialist in that disease to be sure they're on the right track and have a good treatment plan. I think all of the panelists would agree with that.
Yeah, I agree. Yep, I share the same sentiment. I think it's worthwhile to at least get one opinion to make sure you're on the right track. Let's move on. The next question is regarding high-grade neuroendocrine tumor. And a patient is describing a situation where they have multiple metastatic disease. They received PRRT, and now they're getting maintenance octreotide. First of all, panel want to comment on PRRT for high-grade neuroendocrine tumor?
Well, just a few points. I think, first of all, there's going to be a whole talk on high-grade neuroendocrine tumors this afternoon. So I think that's not worth saying too much about that, so I don't step on anybody's toes. But I would just want to say, once again, that high-grade neuroendocrine tumors these days are divided into well-differentiated high-grade neuroendocrine tumors and poorly differentiated ones. This is not lung. Lung tumors are called typical or atypical, or otherwise they're very aggressive kinds, and it's a slightly different area, but the basic principle still applies. That there's a whole spectrum of aggressiveness that goes from a really slow-growing carcinoid to a pretty aggressive kind of cancer. The high-grade ones tend to be in the more aggressive group, but the kind that get PRRT are usually the high-grade, well-differentiated ones that have a strongly positive somatostatin receptors on imaging. And for that group, it's perfectly appropriate to use a somatostatin analog in people that have the somatostatin receptors to treat with PRRT and to treat with the somatostatin analog, even though that might not be the main focus of primary treatment in the beginning. It sounds like a good plan, but I think I don't want to say too much to step on the toes of the person coming this afternoon.
Very good. I understand. There's another question here regarding the management of someone with neuroendocrine tumor and liver metastases who needs a Whipple, but I think may be able to address this in the surgical talk next. So I don't want to give away too much. So I can save that question for later. There's another question here which I don't fully understand, so I apologize that I may not get it correct, regarding a tumor adherent to the abdominal wall. So I apologize. I don't understand that question specifically. But I think that's all the questions we have. I guess anyone want to have any final comments to wrap up this section?
I've got some questions that were posed to, that were sent to me, so I'll address a couple of them if you don't mind.
Perfect. Absolutely. Thank you.
Okay. One question was, can someone discuss the use of SSRIs for depression? Are they safe with NETs, or do they affect serotonin levels? My understanding with that is that the serotonin reservoir in the brain is different and separate from the serotonin in the peripheral circulation. So unless Dr. Wolin has evidence to the contrary, I don't think that there is a real interaction. Of course, patients have to be monitored anyway. But I think it can be used.
I basically agree. There are a few anecdotal cases out there of people who had bad reactions with worsening carcinoid syndrome associated with those drugs. And for those rare individuals, you just don't use it. But for the vast majority of people with carcinoid syndrome, it doesn't make any difference.
I agree.
And you can go ahead and use it.
Okay. Next question that was posed to me was, since my cancer has metastasized to my liver, is ablation of the tumors in the liver still possible? And yes, of course, there are criteria that the interventional radiologist will use as far as the size, the number of the tumors, how accessible they are, and what modality to use. But yes, it should certainly be discussed in a multidisciplinary session. I think everybody would agree with that.
Right.
Okay. Are PRRT and Tristat available at major cancer centers, or does one have to travel to specific locations? They're very different. PRRT should be done at a major center as far as I'm concerned. It's not just the technique, but is also very careful monitoring. There's all kinds of fluid shifts and possible kidney damage that needs to be managed with very tight fluid control and electrolyte management. So I think that needs to be done at a major center with people that are familiar with it. Telaretristat is not. It's an oral medication, and it can be used in conjunction with the sandostatin or lanreotide, and could be added with anybody with uncontrollable diarrhea who's already on those medications. There was a question for Dr. Ramirez. I was recently diagnosed with DIPT. Is there any treatment for that? I do have patients with that, but I think you are the expert on that. So.
Yeah, so DIPT is a pretty uncommon disease. So yeah, there are certainly treatments available. The majority of my patients they get misdiagnosed with asthma or COPD and have sort of gone through those treatment paradigms already. So sometimes we don't need to do anything. It depends on the symptoms, but it ranges from inhalers to oral steroids to sometimes we use somatostatin analogs. We found that those can be beneficial in patients with really severe disease. Sometimes are referred for transplant.
Okay, let me see. There's a couple of more here. There's going to be one that I'm sure Dr. Zaks will address later, which is there a medication for serotonin affecting my heart valves? So I think he'll address that later, but the answer is yes. But I think he'll go into more detail. There was a question on why I feel MRI is better than a CT. And I do feel strongly about that. CT is so the scans, as a general oncologist, scans to me are divided into two broad areas. One, a scan is anatomic scan, and the other is a functional scan. CTs and MRIs are anatomic scan. They tell you what the anatomy is, if there's a growth, how big it is, where it is, etc. Doesn't tell you if it's metabolically active. The PET scan, whether it be the routine FDG scan or the Gallium scan that we use for NETs, that's a functional scan. That tells you if it's functional. The MRI, and they can be combined, either one. You can have a PET CT or a PET MRI. But the MRI, to me, is a much more definitive scan. It's the resolution is much better for neuroendocrine tumors. Ed, do you feel any different about that?
Just one comment. When an MRI of the abdomen and pelvis is done with Eovist instead of gadolinium, the normal contrast is called gadolinium. But if you use something called Eovist, it gets excreted into the bile ducts, and you not only see arteries and veins, but also bile ducts. And with that contrast agent, you can see 20% more than any other type of MRI for looking for liver metastases. So that, since that's such a major problem with neuroendocrine cancers, we tend to use that almost always for imaging neuroendocrine tumors. And the thing about a CT is it has, to do it properly, you have to do what's called a triple phase CT of the abdomen. So you have good distinction between what's a tumor and what's not a tumor in the liver. If you do a triple phase scan, you actually use quite a bit of radiation. You have to scan with early arterial phase, late arterial phase, venous phase, no contrast phase. You keep scanning the abdomen and pelvis over and over and over. So it adds up to a fair amount of radiation. And if you're going to do a scan every 3, 4, 6 months, it's a lot of scans in somebody with a long lifespan with neuroendocrine cancer. An MRI uses no radiation whatsoever. It just makes a picture with magnets and radio waves. So not only is it a better test for looking at liver metastases and many other areas where neuroendocrine tumors are involved, but also does it without using radiation. So I try to use an MRI as much as possible. And for people who are outrageously claustrophobic and can't do it, people who have no insurance coverage that will deal with an MRI or other situations, we have to rely on a CAT scan of the abdomen and pelvis. For the chest, however, a non-contrast CAT scan is better than an MRI for looking at lungs because of respiratory problems when it's the slight movement with respiration. So that uses very, very little radiation. A non-contrast CT is all you need to really see the lungs well. And you could do that over and over and over without having to worry. So I use CT routinely in the chest. Most of the time, you don't need contrast. If you do need contrast, you use contrast, but it's better than MR for that location. There's some specialized things in the chest where MR is still good, and then mediastinum, cardiac MRI, but those are specialized things, and I'm sure Dr. Zaks will talk about that a little bit later.
That's great. Thank you. I have one more question that I think is important because it comes up in my practice a lot. And the question was, after my mother's diagnosis about 2 months ago, she was started on octreotide. She has no symptoms. Would you suggest she be switched to lanreotide for growth control of the tumors? So that comes up in my practice a lot. My answer is going to be no, but I think Ed, you want to address that and why?
Okay. Well, the problem is that there was a study done which was shown briefly in the discussion of lung tumors that Dr. Ramirez showed of PROMIT. PROMIT is a randomized trial of octreotide and placebo. The people that got octreotide had a median progression-free survival. In other words, a median cancer control period of 14 months. Now, if you look at the clarinet trial, the people that got a placebo and got absolutely nothing in the way of treatment had a median progression-free survival of 18 months. And the time of tumor control extends for many, many, many years. So the question is, why did people on clarinet have a longer cancer control than people that got treated with octreotide? And it's a very complex question, and we really don't have time to talk about all the hypothetical answers to it right now, but it's very interesting. So really, there's no objective data to prove that octreotide is as good as lanreotide. However, people were using octreotide for years and years and years before lanreotide came out with excellent results. And clinically, it seems to do about the same thing. And if you look in the laboratory on octreotide and lanreotide's effect on cancer cells, it's exactly the same on neuroendocrine cells. It does the same thing in the same way, to the same degree. So theoretically, both drugs are fine. And if I have a choice and somebody up front, I tend to go towards the FDA-approved anti-cancer drug right now, which is lanreotide, which also can be done with a subcutaneous injection once every 4 weeks, which is a little more user-friendly on people's backsides than a deep intramuscular injection. But on the other hand, if somebody's on octreotide, they're tolerating the shots well, they're not having a problem, and it's working, I tend to leave them on as well. I do exactly the same thing as was said before. If you're on a winning horse, why jump off in the middle of the race? You don't know. They are different drugs, even though they're doing the same thing. And if octreotide's doing the job and not having a problem, I tend to stay with it as long as it's working.
Thank you. That feels good to me as a country doctor, that the expert agrees with what I would do.
There's a question from the audience regarding any experience with MRI PET versus CT PET, or I guess even MRI gadolinium versus CT gadolinium, dotatate. Sorry.
I didn't see any.
CT gadolinium isn't really an
I'm
issue
sorry,
because CT has to be done with a CT contrast. It's a different agent.
I apologize. I meant CT dotatate. So a dotatate scan fused with CT versus MRI, or MRI PET versus CT PET.
Well, people have done studies to see if one is better than the other. And so far, there's no conclusive evidence that one is better than the other. Nobody's really been able to prove that. Although all of us treating neuroendocrine cancers think that probably it's going to be nice when MRI fused with PET, it becomes more generally available and paid for by insurance companies, which is a challenge right at the moment. There are some issues in terms of fusing them. The MRI takes much longer than the CT. And meanwhile, people are in the gallium scanner, and whether it's going to give the same resolution and whether it's as good as MRs in other situations, we have a lot of things have to be sorted out. But I think that it may be something that around the corner is going to be used a lot more, and we're all going to be happy with. But I can't prove it to you right now. I don't know how other people feel.
Agree. I think there's no data for it. Our institutional bias is to do these scans with MRI. So we fuse our MRIs with the dotatate and PETs. And this way we can do a concurrent MRI of the liver at the same time for these patients. So our bias is to use MRI, but there is no data regarding superiority of one or the other. But as you mentioned before, anything to decrease long-term exposure from CT scans is probably worthwhile for those who are going to have multiple scans. But I agree with you. I don't think there's much difference. Another question regarding surveillance patterns for neuroendocrine tumors, specific imaging. Does anyone recommend or a functional scan such as PET or yearly dotatate scans for surveillance? Tough question. A lot of patients request. Dr. Wohl, in your practice, your surveillance, you use functional scans?
Okay, I don't have an automatic practice that everybody who has a neuroendocrine tumor needs a gallium dotatate or surveillance every year. I think that we have to say, what is the situation? What are we looking for, and what are we following? Remember that the anatomic imaging, the CT or MRI, is really the only way to measure tumor size. And if the goal is to maintain control of cancer and you're treating with a drug that controls cancer but doesn't make it disappear, it just controls the cancer, it keeps it from growing, and you do an MRI and the cancer is exactly the same size and all the tumors are the same, and you don't see any new tumors, the chances of having a major insight that's going to change therapy on doing a gallium dotatate is actually very, very small. And it's probably not worth the radiation of doing a CT of neck, chest, abdomen, and pelvis and the radiopharmaceutical and doing it over and over. I know some people are doing it every 6 months or every year, and nobody could say, is it right or it's wrong? They're just different patterns of what people do. But my practice is to use it if I think it's going to make any clinical difference. So I do scans like that, functional scans on all newly diagnosed patients. I think finding out the status of somatostatin receptors is critical. Are you going to use a somatostatin analog or not? How are you going to approach the patient? I think it's a good idea. It also has important prognostic information. I use it again anytime people start progressing, and PRRT is even a discussion or a possibility. I would get another functional imaging of somatostatin receptors, gallium dotatate or coming up copper 64, and see what is going on with somatostatin receptors and whether the patient's a candidate for PRRT. And if there's some equivocal thing on the MRI or on the CT and you just don't know what it is, sometimes you need a gallium scan to sort that out. It's clinically very useful. You can't tell if something's a scar or it's living neuroendocrine cancer. You can get a gallium dotatate and it'll tell you. So I do it individualized depending on the patient. There are a few people where, for example, a surgeon will go in and find the entire abdomen is full of little tumors. And they're just like little teeny dots. They're all over the place. So they know it's metastatic cancer. The patient has started on a somatostatin analog, and you don't see anything on an MRI or on a CT. And sometimes the only way you could follow that patient is on a gallium dotatate. So in that patient, then I would get a routine follow-up using a gallium dotatate, because otherwise you wouldn't have any idea what's going on with the metastatic tumors until they get pretty big. So again, you have to individualize. That's my approach.
Dr. Garcia-Ramirez, you want to add anything?
I agree 100%. I will not repeat scans that may not influence my clinical decision making for the patient. So I like to minimize the exposure to unnecessary tests or radiation. But I think that Dr. Wolin put it very well.
Yeah, I agree. I think, it's a minority of patients where, I mean, certainly you need to individualize to and get that anatomic imaging. That's pretty standard to look for growth. We're not going to see growth on that PET. The only time I'm really following PET is Dr. Wolin pointed out, those patients where you're not seeing anything on anatomic imaging, and the only thing you see is on the functional imaging. Even some of these, small bone mets, for instance. A lot of times you're not seeing them on that anatomic imaging, or small lymph nodes, or occasionally we'll get things where they have orbital lesions or something odd that really shows up good on the PET, but you're not gonna the anatomic imaging not so well.
Can I just add to everybody who's listening, all the patients and caregivers? That's one of the hardest things to understand, that why we're not repeating the Gallium scan every 6 months. And I get that question all the time. I'm sure you guys do as well. And that's the reason. The reason is the Gallium scan is not going to tell us as much about the status of the disease, or the progression of the disease, or the response. It won't tell us as much as the anatomic scan, as the MRI or the CT. It'll give us much more information. The Gallium scan is only used to elucidate what a spot or a lesion may show up if it's unclear to us, if it's metabolically active, if it's related to the neuroendocrine, or if it's scar tissue. And that's where it will help us. But the anatomic scan is much more important to us in following our patients.
There's another audience question regarding a patient with a pancreatic neuroendocrine tumor with a 6-year disease-free interval with a metastatic foci to both the spine and the diaphragm. But if we just comment, what would be the treatment options for someone with maybe an isolated bony metastasis to the spine?
So I think in our group, I guess you're looking at that oligometastatic disease. So they have that disease. So I mean, your options are systemic treatment, in generally with an SSA. But they pointed out 2 different sites. So now we've got it's in what is likely the case is there's also disease that we're probably not seeing on the scan. So not every tumors need to grow to a certain size before we start seeing them on the scan. So even though we're only seeing these 2 areas, I think systemic treatment is probably indicated here. If that disease in the bone so bone disease causes a couple different problems. So one, it can cause pain. So if it's painful, there can be a role for radiation, and that generally relieves that pain. Sometimes the interventional radiologists, they've gotten really good at ablation on these. So that's also a tool. The other thing that disease in the bone is it can weaken the bone, setting you up for a fracture. So in many cases, we'll use agents like zoledronic acid or denosumab to try to prevent that fracture.
Okay.
Agree.
Great. Waiting. I think our time is up, unless I hear otherwise. So to thank all the panel, all the members who spoke today.
Yeah, Dr. Sasson, if you have 1 or 2 more questions, we can cover them.
Okay.
Yeah, but limited to 1 or 2, and then we'll.
Okay. Let me take a look. There's a question here that we may address in the afternoon session as well, but I'll have the panel here discuss if a patient needed preoperative shrinkage of a tumor prior to surgical intervention. What is your treatment options for such a patient? So let's say a bulky tumor may be locally advanced and they want some shrinkage prior to resection. Challenging problem.
It sure is. In the case of a pancreatic neuroendocrine tumor, this comes
I
up
think
because
from my standpoint, this comes up.
Go ahead, Dr. Wolin first, and then Dr. Rimmer. Sorry, both of you.
Dr. Wolin.
Okay, sorry about that. Okay, the time where this comes up most frequently in my experience has been in pancreatic neuroendocrine tumors, where criteria for surgery are such that even a little bit of shrinkage sometimes can make a big difference, whether it's possible to safely get it out because of all the arteries and veins that are wrapped all around the pancreas. The treatment, which is most effective in shrinking pancreatic neuroendocrine tumors, is capecitabine and temozolomide, so-called CAPE-10. That combination will cause a major reduction of tumor, like 30% or more shrinkage of cancer in about a third of patients. And most of the patients have some degree of shrinkage. So if they have not previously had capecitabine and temozolomide, let's say they're relatively newly diagnosed, and there's a question about whether this could be removed, I would use that right off the bat, along with the somatostatin analog if they have somatostatin receptors, and try to shrink it. And then go to surgery. And I've done that many times with success. Other treatments are possible, but most people treated with somatostatin analogs, people treated with everolimus, people treated with sunitinib, and all these other drugs, there's a whole big list of things you could do, don't shrink it enough to really make a difference. PRRT sometimes shrinks cancer, but as we saw, it's only about 19% of patients that have a significant shrink. And most of the time, it doesn't shrink that much that you can count on a shrink. And that's how I would approach it. Now, with other sites, if it really did make a difference, then you have to say, what is the best way to reduce it? If it's in the liver, could it be done with ablation of an area using yttrium-90 embolization? There's a technique of doing that. Should the patient have hepatic artery embolization? Should tumors be treated in other ways before surgery? But you have to really individualize it for our patients.
There was a question from regarding if you have if you have a small bowel neuroendocrine tumor, so you have carcinoid, but you don't have the syndrome, do you still have to be worried about carcinoid crisis?
Yes and no. Okay, most of the time when people have a carcinoid crisis, it's because they have a carcinoid syndrome. But sometimes people have midgut carcinoid tumors that are making serotonin, and you could have elevated levels of serotonin in 5-HIAA, even though you don't have a syndrome. And those patients certainly do have a risk of getting carcinoid crisis. And anesthesiologists operating on those patients should be prepared to act and to use aggressive treatment, as we talked about, to try to prevent a carcinoid crisis, because it can happen in that situation when you push the patient hard enough with things like anesthesia or direct manipulation of the liver in the operating room. So I wouldn't say it can't happen, but it's less common for sure. But when it does happen, it can be severe. So the anesthesiologist has to be prepared. Does anybody else feel differently?
No, I
agree.
Yeah, my patients who are planning for surgery, I usually communicate directly with the anesthesiologist and the surgeon and ask them to have a protocol on hand, whether it be immediate release or IV octreotide in drip form for the patients.
Right.
Aaron, you feel the same way, I'm sure.
Agree. Yes, I'd say we would even prophylactic. We are liberal with a prophylactic, even though there's no data regarding the prophylactic administration preoperatively for a major liver resection per se. The downside is also very low too. So we take precautions. Do you routinely get 5-HIA on all?
To be safe than sorry.
Yes. Last question. Do you routinely get 5-HIA levels on all small bowel neuroendocrine tumors, even if they have no symptoms?
I personally get plasma 5-HIAA, which is a very easy blood test to get. So at the same time, I'm drawing pancreastatin and chromogranin A and serotonin. I get plasma 5-HIA, so it's very easy. To be on a difficult low serotonin diet and collect urine for 24 hours is more of a pain. and it's much harder to get patients to cooperate with that and to get doctors to be meanies and order it from their patients. So it's hard to do that. But if you get plasma 5-HIA, which is now available, it makes it very easy to monitor.
Well, wonderful. That was a fantastic panel, and I thank the audience for their questions, and of course, thanks once again to our panelists who have opted to spend their morning with us, which is very nice of you. We appreciate that, and you're helping a lot of patients here. There were the audience was tipping just over 100 folks, as far as I can see at this point. So, thank you very much for that.